Contra Lateral C7 transfer for post-stroke spasticity. Contra Lateral C7 root, a branch of the brachial plexus, is transferred in a surgical technique to repair damage to a peripheral nerve and is well documented in brachial plexus injury. By transferring this healthy nerve root from the opposite brachial plexus to the damaged side, it provides axonal energy to restore function to the affected limb. Spastic limb paralysis due to injury to a cerebral hemisphere from stroke, traumatic brain injury, or cerebral palsy produces long-term disability. It is estimated that 30 to 60% of stroke survivors are unable to use their paralyzed hand. The functional impairment is due to the interruption of the inhibitory activity of upper motor neurons, producing spasticity, and associated weakness and loss of fine motor control of the hand. During the recovery phase, neural reorganization can occur in both the post-lesional hemisphere and the contra-lesional hemisphere. This process of neural reorganization involves the formation of new connections between neurons and the rewiring of existing neural networks to compensate for the loss of function caused by the lesion. Treatment for spasticity in stroke typically involves a combination of medications, physical therapy, and in some cases, surgery. The goal of treatment is to reduce spasticity, improve function, and manage any associated pain or discomfort. Surgery was traditionally used to release the tight muscles and tendon release surgery, deformity corrections, or remove damaged tissue. Some of the surgical methods attempting at reducing spasticity include selective dorsal rhizotomy and selective neurectomy. These reduce the electrical overactivity in the affected muscles, which involves cutting the specific nerve innervating the index muscle. In 2018, Zheng et al., from Shanghai, China, postulated the paralyzed hand in stroke patients could be functionally connected to the contralesional, ipsilateral, hemisphere by transferring a cervical spinal nerve from the non-paralyzed side to the paralyzed side. In this RCT, they investigated the effect of grafting the contralateral C7 nerve to the paralyzed side in patients with spastic arm paralysis. They showed improvement in functions of the upper limb and reduction in spasticity. Through transcranial magnetic stimulation and functional imaging, they showed connectivity between the ipsilateral hemisphere and the paralyzed arm. The second phase of recovery was characterized by improvements in muscle power and motor function, which were most evident beginning at approximately month 10, attributed to the regeneration of nerve fibers through the gap between the distal end of the transplanted C7 nerve, and more distally, on the side of the paralyzed hand. Donor C7 nerve morbidity included weakness at the elbow and in wrist extension, as well as numbness in the thumb and index and middle fingers and pain. Other studies have corroborated these findings, and, in this lecture, a narrative synthesis of these studies will be presented as the current body of evidence for this procedure.